Welcome back. In this video, we're going to be discussing monoamine oxidase inhibitors, corresponding to Chapter 71 in Goldfrank's Toxicologic Emergencies. The learning objectives for this session are that you'll be able to describe the biochemical mechanism of monoamine oxidase inhibitors, MAOIs, and how this relates to the signs and symptoms you'd expect to see with toxicity, and to explain what the heck I mean when I mention the cheese reaction. It's a common theme in pharmacology that some new drug or class of drugs is discovered that has some new therapeutic potential, and we're happy because now we've got more ammunition in our arsenal. There are some toxicities or adverse events associated with these new drugs, but we have to tolerate them because we don't have any effective alternatives. Later on, though, an even newer drug or drug class is developed that works for the same indication, and it may or may not be more effective, but it has less side effects or toxicities, and we shift our use away from the older drugs. This common theme has been seen with antidepressant drugs, where the monoamine oxidase inhibitors were the first widely used class of antidepressants starting in the 1950s. They worked, but they were terribly toxic in overdose situations. The MAOIs were supplanted by the tricyclic antidepressants, or TCAs, starting in the 1960s. Today, we think of TCA toxicity as being terrible, but they were a major step safer than the MAOIs. And this happened again when the serotonin reuptake inhibitors hit the scene in the 1980s, which are even less dangerous than the TCAs in overdose. So now we're two drug generations beyond the high reliance on MAOIs. It'd be quite rare to see patients today with monoamine oxidase inhibitor toxicity, so this video is going to be pretty short and superficial. This used to be a major topic in clinical toxicology, but it's mostly a historical footnote now. I haven't seen a patient in the emergency department where I was concerned about MAOI toxicity since the one patient I saw twice when I was a resident in the late 1990s. Here we can see that MAOIs are structurally similar to amphetamine, giving us a clue regarding what effects might be seen. And they are currently used quite infrequently such that MAOI toxic cases are rare. If you see a patient today on a monoamine oxidase inhibitor, most likely it will be selegiline or a closely related drug used in the treatment of Parkinson's disease. And this is not a patient population as likely to intentionally overdose on their meds as patients being treated for depression. As the drug class name suggests, MAOIs inhibit the enzyme monoamine oxidase, which is the enzyme responsible for breaking down biogenic amines, resulting in increased levels of norepinephrine, dopamine, and serotonin, which ought to improve the patient's mood at therapeutic dosing. But in overdose, we can imagine this resulting in exaggerated effects from the accumulated norepi and dopamine, which have prominent effects on the cardiovascular system, increasing blood pressure and heart rate and potentially resulting in a hypertensive crisis. Patients might complain of headache, chest pain, and/or palpitations. With an acute overdose of MAOIs, a biphasic response is classically described. First, though, there is some latency where the patient can remain asymptomatic for several hours. Then there's the first phase of neurologic and cardiovascular hyperexcitability related to the surge in biogenic amines. The neurologic effects can include agitation, tremor, hyperreflexia, seizures, hyperthermia can develop, along with extreme hypertension and various tachydysrhythmias. Then the second phase of neurologic and cardiovascular collapse can follow, where the patient is now hypotensive with either tachycardia or bradycardia, more cardiac dysrhythmias, and there is a risk for sudden death, even with aggressive supportive care. A very interesting side effect of MAOIs seen with therapeutic dosing is the so-called cheese effect, or cheese reaction, or tyramine reaction. There are several foods that contain relatively high levels of tyramine, which very closely resembles the biogenic amines. On the list here we see that these are mostly foods that are aged or fermented. Normally, when we eat tyramine-rich foods, we never absorb much of the tyramine because it is broken down by monoamine oxidase in the gut. Thus, there's a huge first-pass metabolism of tyramine, and everything is okay. Go right ahead and eat those tasty aged or fermented foods. But if the patient is taking MAOIs, this allows a lot more of the ingested tyramine to be absorbed. And because it's so structurally similar to our normal biogenic amines, the tyramine is uptaken into noradrenergic nerve terminals, where it acts as an indirect sympathomimetic agent, causing release of norepinephrine and dopamine, potentially producing a hypertensive crisis. Therefore, patients prescribed MAOIs need to be educated regarding what foods to avoid so they won't get headaches, nausea, palpitations, and chest pain if they eat the wrong things. The patient I mentioned that I saw twice as a resident had tyramine reactions after eating food containing soy sauce. Also, back when MAOIs were more frequently used, most cases of serotonin syndrome were associated with MAOIs compared to any other pro-serotonergic drug class. Of course, now that MAOIs are a lot less common, they're no longer the #1 associated drug class. And you can hear more about serotonin syndrome in some other videos in this series, including the ones about toxidromes and serotonin reuptake inhibitor class antidepressants. And that's all I've got to say about monoamine oxidase inhibitors. I'll be seeing you around.